Good evening, everybody from thunderstormy Miami. I'm Dr. Lanka Mahesh. I practice in New Delhi, India. I want to thank the XP team for having me present a webinar on immediate implants, and I thank Maurice, Eddie, and Henry and their team for having me over for this presentation. Immediate implants is a very controversial topic in many parts of the world. It's an accepted protocol, and we know that they work very well. I'm going to talk a bit on immediate implants and a little bit on socket grafting when immediate implants are not feasible to do in some anatomic situations. We look at a lady whom we had operated a few years ago, and this was published in the Clinical Practical Oral Implantology in the US in the 2011 March issue. We had this lady who had complete loss of video, thinning lips, her jaw relation was completely awry. You can see the nasal labial fold. She was in a very bad situation. She was fully dentulous and not very old. She was only 56 and very conscious to God about her appearance. We just placed, this is not an immediate implant. We are just trying to show you what we can do with implants. It's a 4-implant overdenture in the upper jaw and 3 in the lower with an extended flange. And we could give her a sense of a semblance of dignity with which she could go out and face the public, eat food properly, and she definitely looks a happier woman. So what we are trying to get out of situations, even a simple situation such an implant overdenture, is that in the 80s and 90s it was all functional therapy. Today all that we are doing is aesthetic implant therapy, whether it's a single tooth or it is multiple, full mouth, whatever. You're trying to look at aesthetics. That has become the base for all our implant dentistry or any other restorative dentistry as well. One of the finest articles to come out in the recent times is from Furhauser's team. This article came out in COIR, the Pink Aesthetic Score, which gives you 7 variables: the mesial papilla, the distal papilla, the height of contour, the color, the texture, the jugulum. So it gives you a scale of 14 points where you should, each 7 points have multiplied by 2. So you have to stand as close as you could to 14. When we look at socket preservation versus immediate implants, where do we stand? Socket grafting has been published in the literature a lot, and so has immediate implants been done. We look at Mark Kunin's article, how does the timing of implant placement to extraction affect the outcome? If you look at the conclusion in the article, it says that due to less data available, we are still not able to be sure that immediate and delayed implants have scored the same on peri-implant health, bone loss issues. So despite there being numerous publications on immediate implants versus delayed or delayed versus immediate, all in the end, unless you have a complete consensus statement, there's nothing that goes to say that immediate implants won't work or delayed work better. The outcomes are usually the same. We look at the global map of immediate, early, and delayed. The advantages of immediate are reduced surgical sessions. The patient is happier not to go under the knife multiple times. Versus delayed, you could have buccal wall collapse if you don't do a socket graft. And the early one, you get good soft tissue closure in 8 weeks or so. But again, there could be up to 20% buccal bone loss. We look at the article from Arau and Linde's team that says dimensional of the facial bone in the anterior maxilla. If you look at an average adult human being, the facial wall of the lateral or the central or the canine in the upper jaw would be anywhere from 0.6 to 0.9, which is hardly anything. And if you do a traumatic extraction or you extract the tooth, don't place a socket graft or a bone graft, the facial wall tends to collapse. And then when you come back, you're trying to regain all that by doing your GBR and procedures such as those. Again, from Arau and Linde's team, one of the most read articles on the PubMed is dimensional changes in the canine model following a tooth extraction. We all know that the maximum bone loss that occurs is in the first year, but it's very accelerated in the first 3 months. So we either do an immediate implant to prevent socket wall collapse, or if not feasible, for example, especially in the lower molars or the uppers, sometimes the sockets are too wide to incorporate an implant, and there could be interceptal bone breakage due to your extraction procedures. It would be always safer to do a socket graft and re-enter. So you have healthy bone, you have mature osteoid, and you can go bang into the middle of the socket without worrying that the implant is going to slip, especially in the posteriors. This is something that me and my colleague Narayan published in the JOI a couple of years ago, rich preservation with socket plug technique, where we were comparing a particular xenograft versus a calcium phosphosilicate putty. The product used in this study was Novabone, and we concluded that CPS putty is a reliable source for doing socket augmentation. Another publication of ours, this was a multi-country study from Aaron Gonshore from Canada, myself and a few colleagues from France. Again, we had the conclusion, high percentage of vital bone content present in our histological cores suggested that CPS putty is a reliable source for socket augmentation if you cannot do an immediate implant for any anatomical reason. Another of our publications, the JCDP, where we extracted a lower molar. It was buccolingually really wide, and as you can see on the radiograph, this is after placing our CPS putty. The nerve was very, we didn't have much height to place an implant, and we didn't want to take a chance placing an immediate implant and that slips down into the osteotomy and you hit the nerve. We want to be more safe and you want to do a procedure that's predictable. So we do a CPS putty and a 4-month histological core, which was processed in our laboratory, shows us mature remodeling lines clearly and mature bone formation that suggests that yes, CPS putty has good bone turnover and it is giving us good bone regeneration in a quick burst. Again, another one that came out in compendium, me and Maurice Salama and a couple of more people. Again, we did a histological study and suggested the same, that CPS putty is a reliable source for socket augmentation. It works, these kind of alloplasts work best in closed zones, like a socket, like a sinus. So because they're putties, the morsel form we can use in rich contouring, etc. But the putties work very good in closed places because there's good blood supply. And as we know from Linde's studies, the socket, the bone always starts growing from below. So it's not growing from the top. We look at buccal plate, the fate after extraction. This was a young lady who had endodontic failure in the central incisor, though it was crowned. The lateral was endodontically treated but not crowned. She was referred to us by a local dentist. We use a peritome for extraction. I'm very impressed with the word atraumatic extraction that's used all over the world. I mean, imagine getting a local shot, getting a peritome, getting a forceps, an elevator. I really don't believe that it's atraumatic. I like the word minimally traumatic. You try to be minimally traumatic. Nothing, when you're getting a tooth pulled, it can't be traumatic. So you just use a peritome, cut the periodontal fibers, luxate the tooth. So that's atraumatic extraction. No, maybe not, maybe minimally traumatic. You just preserve your tissues. We just let her go. We didn't place a graft because it was heavily infected. We recalled at 4 weeks, and this complete facial wall collapse. Soft tissue has followed bone contours. We know about it. In 4 weeks. So if you see this patient in 1 year, you would hardly have anything left. And we reopened her to place an implant. The implant is a huge exposure. Buccal threads close to 8 mm, 7 mm is exposed. So we went ahead and placed our CPS morsels. Did a prep on the lateral so it could support our temporary crown in the healing phase. Closed with Cytoplast 30 sutures. This is a product I use, tissue adhesive called Pericryl from Glue Stitch. It's just to keep these wounds closed, because if you notice the frenum is high, this patient will need a frenectomy as well. So at second stage, you do frenectomy and you see the bulk that we've gained in 4 months. It's even much more than the natural tooth. We've got nice healing of tissues. We've got a nice tissue collar. We did frenectomy to release the frenum. Post-operative, this is how it looks. This was the lower slide is just before you opened it up. And the upper X-ray and the upper picture is close to 2 years. The implant is stable, the bone levels are stable. It's a nice outcome. But why do we do immediate implants? So to get a shorter treatment time, there's less alveolar atrophy, there's easier definition of implant position, better osseointegration potential, and a shorter edentulous time period, which all patients prefer. Better aesthetics because you can maintain tissues. These are a few results from my own practice. These have been updated up to 2012. Various implant systems like BioHorizons, Alpha Bio, Bionair, Nobel, Biolock, Zyve, so whatever we are using in our practice. It shows a fair degree of success, close to 97%. These are all immediate implant cases. We had the red ones are post-loading failures, the yellow ones are pre-loading failures, which are surgical failures. But shows us a decent amount of success, close to 97, 98% over a period of 6 years. You look at a few case presentations now. You do immediate indirect sinus lift. We're placing immediate implants along with some CPS putty. We had this fractured upper right premolar and molar, and a missing 7 as well. So we extracted those teeth, did our implant in the first missing tooth. In the Pontic area, the roots were extracted and some graft the excess graft was placed there. And distal to that, we had done indirect sinus lift with the osteotome technique and placed another implant there. So if you see the distal implant, you can see a small lift. It's not a very big lift, maybe just 2 mm or so. And the central area has been, the root has been removed and this excess putty has been placed there. And at uncovery, after uncovery, we place our abutments, and I like to do a little bit of deepithelialization of my tissue, whether it's the anterior or the posterior in the pontic area. So you get although this is not an aesthetic zone recon, but still it's good because the pontic fits in snugly, and you get a nice emergence profile. So this is something that I've been doing in the anteriors, maybe in Abraham's roll or a modified roll flap or a connective tissue pouch to get more bulk. But in the posteriors, usually this is enough. Just deepithelize the tissue and let the pontic settle there. This is a 2 years post-op. There's stable bone levels on the panorex. Another technique that we've been working on for quite some time. It's called we're trying to call it DNB technique, no bone technique, because this is a CPS putty that we're using. We have these failed endodontic teeth, curved roots. This has been submitted for publication. We use tapered implants in the study. We use BioHorizons, Nobel, Bionair, and Alpha Bio. We had 122 implants with 3 years follow-up and no failures. This is the laser lock implant from BioHorizon. We extract the root, place our putty, do radiograph post-extraction, do radiograph post the putty. So you know that the putty is filled everywhere, there is no defects, and now you're going to place your implant through it. Instead of what we used to do many years ago, we used to place our implant, and then to close the jumping distance, use a fine instrument like maybe sometimes a 15C blade or maybe a plastic filling carrier instrument to graft the jumping distance. This we can prevent it. So it's much easier. The graft is already in the socket, and your implant goes through, so in a 360 degree it obturates it by itself. So there is no way that you'll have any dead spaces around your implant. The implant goes in and the graft automatically spreads all around wherever there is any dead space. Being a putty, it goes in very easily. It's not like particulates, it tend to slip. And the laser lock portion is left in soft tissue. The implant is left embedded into the bone. That's your final restoration with the zirconia crown, and that's a 3-year follow-up. Your laser lock has maintained its connectivity on the tissue, and bone levels have been stable up to the first thread of the implant. And that's 3 years post-operative. We have a nice smiling patient. The dual zone concept that came out from Maurice Salama and Stephen Chu's team, which says that immediate management of immediate implant placement and provisionalization and restoration in the anterior extraction sockets. You have to look at soft tissue and hard tissue. So that's the case of a failing central incisor, a fractured tooth. Use a periotome, get the fractured segments out, curate well, remove any debris that's there below. Start your drilling and keep it as palatal as you can. That's your pilot burr drilling into palatal bone. That's where you get your anchorage from. Because in these cases, it's very easy for the implant to slip out and fracture the facial bone, and then you end up doing more work. That's the implant used here. That's again a tapered BioHorizon laser lock implant. Implant has been placed. You can see the jumping distance. After removing the abutment, you see the hex. It's got a defect all around. You have to close that gap. These are some PRF clots we use here, packed in our no bone putty and our connective tissue graft. After temporizing, that's the tissue you have all around at 4 months, which is from baseline. It's excellent tissue. You see peri-implant health is perfect. You have good vasculature of the gingival tissue around. That's a zirconia abutment, torque to 30 Newton centimeters. That's the final zirconia crown. Interdental papilla are maintained. And if you look at an occlusal shot of this, you in fact have more bone than the natural tooth around it. That just goes to show you that regeneration work with any kind of graft material that you use, it just has to be more, you have to plan the case. Well, case selection is very important. Like this, probably we could not have managed maybe a lower 6 or a 7, or maybe an upper 6 or a 7. This is one of my favorite cases. It's like an immediate implant along with CPS putty. We say pushing the envelope because these are cases especially not for people who are just starting out into their implant practice. Maybe you had a long canine and with a mobile lateral incisor. So we decided to knock off the canine and place an implant at the same time. We don't use any big incisions anymore. We all know we have to stay away from the papillae as much as possible. And this kind of incisions don't even give any pull on your implants. So we do a small incision into the vestibule, expose the canine, remove the canine, get rid of the mobile lateral incisor as well. You see the defect, it's huge. I mean, the defect is really big. Your whole luxator goes through it. So we pack 1 cc of our CPS putty, pack that in nicely and place our implant is a Nobel NP, 13 mm. And you can see the implant threads exposed completely. So the only anchorage we have is from maybe 2 or 2.5 mm crestal bone. That's all we have anchorage from. We pack another 1 cc of graft from top. It's a big defect. put a small piece of, we used a biomend here, a small piece of biomend, and a few interrupted sutures. So to remove an impacted canine and place an implant and do your GBR, you don't need a big flap and lose more tissue. Temporize here, remove the temporary post-op at 5 months. You see the buccal volume is as good as a natural tooth should be. The jugulum is maintained. There is no collapse of the buccal wall. We do a perio test. It gives us a value of minus 6.1, which is very good on a perio test scale. So we decide to hang on to the temporary. So there's 4 months post-loading. So it's 9 months now since the implant has been done. The graft is still maturing. And this is something that me and Maurice Salama published a couple of years ago in Inside Dentistry. It was this was what the article was: extraction of an impacted canine with immediate implant placement. Look at the palatal canine removal immediate implant placement. These cases are even tougher because you have no palatal support. You have you're looking at only maybe a little bit of crestal support for your implant to be stable. That's the CBCT of the same case. We remove it's a long 22 mm canine. Go ahead and place a Nobel. This is before placing the cover screw, just to check the implant position if it's correct. If you see the implant, the cover screw hasn't been placed as yet, and you just check if everything is correct. And we could achieve good primary stability despite the fact that it wasn't, there was no palatal wall. And that's the final restoration at 1 year recall. This is the zirconia crown, the nice tissue levels. You see the papillae are maintained. This nice buccal bone, and it's nice and aesthetic. This is also a very old case of mine where the patient came to us with a denture tooth bonded on a fractured central incisor, and we decided to remove that central, place an immediate implant. These are just various radiographs that we take at the time of placement, initial drill and after the implant placement. And that's your placement levels. You know, I like to just classify it like the blue, yellow, and black, blue lines, so just we know. This only applies to implants that are, come with mounts. They don't come with mount-free implants, you can't apply this. And then use a healing collar. We just, using a diamond burr, we just shave off from the healing collar from one end, and then that end is pushed below the mesial papilla just to support it. The patient goes out with a one-stage surgery with an Essex appliance. At 4 months, your gingival cuff is ready. It's nice tissue. We do under contour temporary crowns. So at the cervical area, we want to support our tissue. It's screw retained temporary, so there is no issue of any cement leakage. Insertion of temporary prosthesis. You are just pushing the tissue in. You get a little blanching. You're happy. And this is a 6-year post-operative recall X-ray, where the tissues are stable, the papilla is stable, the distal papilla, the colors of the papilla. It's very natural. It's blending in well, and the patient is very happy. We look at an immediate implant with a socket seal, which Kobe Landsberg had advocated many years ago. This is a young dentist who had a fractured central incisor, and there's a fistula as well. It was draining. We removed the tooth with a luxator first, and then use a long handle periotome to get the root fragment out. The implant was placed, and we use a tissue punch to measure the orifice of the socket. The implant placed here was 4.6, so that's why the tissue punch was 5 mm. We go to the palate, harvest a small dual connective tissue graft, which has epithelium on top and connective tissue at the bottom. We use a buck file and clean the whole socket with a lot of saline, and then we do our implant placement. It's again a 4.6 biorazor implant. The graft is removed very gently. Now you have a dual graft epithelium on top and connective tissue at the bottom. After you deepithelize the area with a small file, so you get fresh bleeding around the gingiva. It is stabilized with 30 cytoplasm sutures. If you see the palatal wound, there's hardly any bleeding anymore. It just stops in 2-3 minutes. Sometimes I use a small cola tape with pericryl, but if it's really small, I just leave it alone. It tends to heal up easily. Temporaries, we gave her a Maryland on the day of surgery, which was shifted to a Essex retainer after 4 weeks. That's your healing after 4.5 months. That's your abutment. This was published in Colombia by me and my colleague Joshua. That's the final zirconia crown and a nice smile for the young lady. The whole idea is to be minimally traumatic to the patient and do what appeals to you the most. This is the fractured tooth, endodontic treatment, no crown, periotome, gently. The implant placement may take you very less time, but the extraction should be done as gently as possible to preserve whatever tissues you have. So very gently, with rotational force, we remove the crown, and then we remove the root of the luxator, apicopalatal drilling to get stability from the palatal wall. That's the implant we used here, a bioresonance tapered internal. The implant was placed, and then the connective tissue was harvested from the palate. We got around 35 NCM insertion torque, which is what we all desire in our implant patients, so that it's more, you're confident, because primary stability is the key. Now this is what we could have avoided with the NB technique. Now this is a very old case, so we used to do this. We used to pack the jumping distance with particulates, and the graft would be falling everywhere. You waste a lot of graft and just add to your surgical time. So this was what we were doing before, not anymore. And then the punch that has been taken, the Dentsply rotary punch on a 20:1 handpiece, is placed over the area. We leave a little bit of gauze over the palate where you have harvested the tissues just to stop bleeding. And that's your connective tissue, which is bilayered. The epithelium is on the outside, and the connective tissue is inside, which is going to adhere to your tissues. We use, again, monofilament sutures. I have all my implant surgeries, as far as possible, I try to use monofilaments. I don't use any silk. If you go back to some articles from Note, they show you human reactions to silk and EP, TFE. So we ourselves have done a few studies of our own where we compared Vicryl, gut, silk, EP, TFE. So any implant case, as far as possible, I like to use a monofilament. If you don't have this kind of suture available in the area you practice, you could also use a nylon. But the only issue with nylon is it tends to be very sharp, so it can poke the patient, creating an ulcer in the lip. That's the Maryland, which is modified in such a way that it just presses the tissue gently. Not very, you don't want to get any necrosis by putting heavy forces on that, but very gentle pressure, so you know that the tissue is going to hold up well. And after 4 weeks, we had shifted her to the S6, and this is a final zirconia crown. And that's a 5-year post-restoration, stable bone levels. Another case of a young lady who had amelogenesis of her teeth. So a dentist initially 10 years ago had put a PFM bridge. The bridge was chipping off, and the canine had some internal resorption. So that was removed and an implant was placed. It's a 4-month healing. That's your post-operative canine implant with nice tissue levels and good mesiodistal papillae and the bone levels as well. Look at another case of an endodontal treatment, a very funny kind of endodontal treatment that was performed for this young girl. Extracted the root fragment and placed our Nobel 3.5 by 13, and the putty was placed into the buccal deficit. At insertion and at 3-year recall, the tissue is stable, you have nice papillae, mesial distal, color, contour, everything is fine, there's inflammation. It's all in a very harmonious situation that we have. This is a very old case, but one that I really like. This is the probe is where we want our soft tissue to be. In the uppers, it's very easy to do a Palachi roll or a buccal roll to get tissue, but in the lowers, to get that kind of tissue is difficult. Although we had a lot of bone, in fact, the posterior implant is a 5 by 10.5, and the mesial socket implant is a 4 by 10.5. We just put some BIOS chips, put some collar tape, and close it up. Use nylon or cytoplast for better soft tissues. At second stage, we extract our lower 8, which is going to interfere with our impressions and the placement. We do a buccal sliding flap. And sutured here, I had used 4-0 nylon. You can also use your allodome if you want to use. That's human acellular dermal matrix from OsteoHealth, distributed by BioHorizons. I extract the tooth because the upper molar was impacted as well. It was not in function. We get increased width of tissue. That is what we were looking at initially. That's your final splinted crowns on the model. It is a very good time to teach your patient interdental brushing rather than showing him the mouth, which is sometimes a little tedious. You show them how to use an interdental brush between these two splinted crowns. We sent the patient for a radiograph, and if you look at the distal crown, there is a small extension coming off. That usually happens when you leave cement in the lingual sulcus. So it's good like a wake-up call for us. So we call back the patient, use our plastic scalers, and get rid of that lingual cement. This case is nearly now 10 years old. Full mouth rehabilitation for a completely destroyed dentition with mobile teeth, multiple root stumps, Patient was very unhappy with his teeth. We removed the teeth. All the implants were placed flapless except the lower molars, which were healed sides. They were with a flap and a suture. At 4 months post-operative, the implants have picked up well. There is some covered screw exposure. We feel some of the buccal tissue is not much. So we got to do a soft tissue procedure where we give a paracrustal incision. I use a Boozer or a CM 2x4 instrument from Ufredi to move the flap buccal and place our healing collar. So the healing collar is going to support your tissue while it is healing. The same thing on the other side. We used a bone ronger, in fact, to expose one of the implants. Bone had grown over the implant. And then we put our flaps buccal. If you notice on the upper left side, we probably hit a branch of the greater palatine artery. So there's a little bit of bleeding. We use some collar tape with a hemostatic agent so that it settles down. And to bridge the gap, because the whole thing is open now, we use a piece of alloderm, one of my favorite products to use. Alloderm is always best to be soaked in blood for a couple of minutes. So you know that which side is the basement membrane and which is not. The side that absorbs the basement membrane, that's on the right side of your slide, will go on to the host bone, that being your basement membrane. And the other side will be facing you. Use that to bridge the gap. Multiple cytoplast and nylon suturing. 3 weeks post-op, you see this huge amount of tissue that you have all around your implants. You know, this tissue is going to stay. We temporize the case for 16 weeks and then go ahead with our PFM restorations. And when you have tissue like this, it's still raw. It's only 3 weeks. It's still healing. But when you have such thick tissue bulk gain, you're sure that it's not going to recede and your implants are going to be in a stable environment surrounded by keratinized tissue. This is where we started, 2005. This is where we are. It's 2014 June now. It's stable health and everything is good. In another case, this was a really tough one to handle because there's hardly any bone and very poor patient who was not ready for a block graft or iliac rest. No way. If you see the CBCT, there is hardly any bone at all. It's just knife edge. So we extract the teeth, place our implants. You see there's complete buccally exposed. We used some Cerabone here. It's a bovine hydroxyapatite from Botis. And we used a BioGuide membrane on top to close it up. And post-operative, we gave her, it was a nice hybrid prosthesis. She's a nice, satisfied lady now. It's a nice smile line. Acceptable aesthetics based on adequate bone volumes that we got from our GBR. So to summarize, I would like to say optimal implant aesthetics are based on sound bone foundation, good soft tissue profile, adequate implant position, appropriate implant design, and of course good prosthetic support. In conclusion, I would just like to say evidence has clearly suggested us that immediate implants are a very viable protocol today. Compared to the delayed, they work the same in all the literature that we see. Sometimes there could be some issues with soft tissue recession, etc. If you over suture or you open big flaps, that could sometimes be an issue. So socket grafting also is a procedure that is widely been reported in literature. When you cannot do an immediate implant, it's good to have vital bone. So when you're re-entering the area, you're sure that you're surrounded by good osteoid tissue. So some cases might need a socket graft because it may preclude an immediate implant placement. Otherwise, immediate implant placement today is much easier for the doctor and the patient. But of course, in the end, it's all in the clinician's hand. We have to try our best to provide what the patient desires and in what he or she will be in complete harmony of aesthetics, health, comfort, and speech. So with that, I'd like to conclude my presentation. Thank you very much. And I again want to thank the Dental XP team for having me over here in Miami to share my brief inputs on immediate implants with the global audience. I'm sure like and feedback, whatever, and that you have after seeing this. Thank you once more. Thank you very much.